Hi everyone. Okay, so I have this is off topic, but I have two laptops and one of them is making a heck of a lot of noise, I notice. So I'm recording on my other laptop and I'm hoping every time I speak you don't get that feedback. I may have to purchase a microphone to make it so the sound isn't so scratchy every time I talk. Okay, so we are going to be talking about critiquing films and mounting films. So critiquing an FMX, what are the criteria? We want to evaluate every single film we take. And the reason why we want to critique it is because if we are able to identify the mistakes, whether or not they are correctable or not. I mean, they may not be correctable. There are some people, because of their occlusion, no matter how many times you try to open up a contact, you just can't get it for some crazy reason because you can't get the sensor in the right place and you just can't get the vertical angulation to line up. Usually you can close everything around it except for opening that one spot. But I have been in situations where it's like, this isn't happening. So it's not about getting every perfect film. It's about understanding what's going on, making sure we look in the patient's mouth really closely, see what's happening with how the teeth come together, the flare of the arch, the size of the teeth, the size of their mouth, the size of their tongue, all this kind of stuff. And then critique understanding if our vertical angulation was off, if our horizontal angulation was off, and just an understanding of all of that and critiquing it correctly. That's what we want. What constitutes a retake? So our goal is to take as few retakes as possible. So we don't want to just say, this didn't work out, I closed my contacts, I'm going to take another one, and another one, and another one. So we, in the beginning on Dexter, there would probably need to have a lot of retakes, but our goal is to get to the place where we can minimize the amount of retakes and still have diagnostic quality on all of our pictures. So errors versus retakes. Errors don't equal a retake. Just because there's an error in a film doesn't mean that you need to retake it. And it may be that it's perfectly diagnostic, really. Maybe not ideal, but in general, the doctor can see what they need to see. So an error doesn't mean a retake necessarily. So what are the errors? And we've talked about this already. Horizontal angulation, closed contacts, vertical angulation, elongation, or foreshortening, a placement error. Maybe the film is too far forward, too far back, beam centering error. You've cut off some of the film, and so radiation didn't ever hit some part of the film. Okay, so technique errors. So closed contacts or overlapping. So when one tooth is superimposed over another tooth, then they have the overlap look. So your horizontal angulation is off. You didn't get the central beam right through those pesky contacts. And this is when we use our Q-tip. After you've used a Q-tip or a cotton tip for a lot of years, you can actually just look at the contacts and just kind of draw that line in your mind and then line up your beam to go through. So you won't always have to use a cotton tip, but that's how we fix it in the beginning to make sure that our horizontal angulation is right. If your overlap crosses the DEJ and it cannot be seen in any other film, it's a retake. If your overlap does not cross the DEJ, the dento-enamel junction, so this here, the whiter part is your enamel, the inside is the cement, the dentin. And so again here, the whiter line is all enamel, and then inside that's the dentin. if it does not cross the DEJ, it is still an error, but it does not require a retake. Now, I'll tell you, this is going to confuse somebody, and I probably shouldn't even say it. We have talked about retakes if it's more than 50% into the enamel, and I'll tell you in lab once I kind of confirm that. I still feel that we should be going ahead with this criteria. If it passes the DEJ, it's a hard retake. If it doesn't, it's an error but not a retake, because I feel like that minimizes ultimately radiation to patients, and oftentimes the doctors can still diagnose. And you can also, in real life, in practice, when you get onto practice, a lot of times if you take a film and there is a little bit of horizontal angulation error, but you can show it to the doctor and say, I didn't quite open the contacts here, but can you see everything you need to? And if it's a high caries risk patient, or they think they see a shadow but they're not sure, they'll probably say, no, take it again and open the contacts. But if it's generally a healthy patient, or they can see pretty good and it's not distorted really, and they can tell there's no shadow, they might say, oh, it's fine, I can see what I need to see. So sometimes you can consult the doctor once you get out in practice and say, is this really something you need me to retake or not? But for our purposes, generally we don't retake it if it doesn't cross the DEJ. But like I said, if there is a change in that, we'll talk about it when we actually get into lab. So make sure that we're all on the same page. So what happens? So we want to do this. We want to go straight. We want that central beam to go right straight through the contacts. We don't want this. So you can see how this part of the molar is going to be superimposed onto this part of the molar. So this, not this. Another technique error is foreshortening. So what's the error and how can we fix it? Well, I drew a little picture. I don't know if this is going to be dark enough. I just realized. Let me go over it really quickly with a Sharpie. So I drew a little picture of a tooth. I should probably have this is one of those skinny Sharpies. It's not one of those big fat ones. It makes a nice big bold line. Okay, let's see. I'm going to hold this up. Let's see if you can see it. Okay. All right. So when you foreshorten, hold on, I'm going to highlight something. When you foreshorten, what you've done, and this is a drawing. I did a little drawing of a bisecting technique, but you can also foreshorten with paralleling, although it's much more common that you would foreshorten doing a bisecting technique. But what has happened here is the central ray that's coming out of the, I'm going to highlight those two so they show up. This is going to drive, I'm sure I'm driving everybody nuts. You're going to say, just get to the point. Okay. So the central ray that is coming out is not hitting the because this is a bisecting, it's not hitting the bisecting line perpendicular. So as those rays come down, they will superimpose, they'll put the image, they'll come at this angle heading down, this angle heading down, and they're going to superimpose the apex here. So this pink dot, that's where the apex is going to be, and then the incisal edge is going to be here, because the central rays are coming down at that angle. I'm just going to look at the picture instead of looking at myself. Wouldn't that be easier? So the central ray, so right here, you can't really see it, but I have a bisecting line right through here. And really, this PID should be coming at this angle. It should be coming this way to get a true picture of the tooth. But instead, the operator has put the BID up too high. And now the central ray is going to impose the picture down here on the sensor and then down here. So you have a foreshortened. So the tooth is going to look, I'm going to draw it in pink. So the tooth is only going to look this big. It's going to smush it down. It's smushing the tooth down, and it's only going to look that big. You see where the line is that I drew right here? So it's going to smush down the image of the tooth onto the film, because that's where the direction, the angle of the central ray is going to come down and then take a picture, kind of be absorbed into the tooth at the different levels. That's why we get those different shades of gray. And then that image is going to be deposited onto the film lower than the actual tooth is in the mouth. So that's what happens. So the image gets kind of shrunk down. And I was in the textbook, in the chapter on bisecting, I believe it's in the chapter bisecting, it talks about if there's a tree and the sun is rising, at the different levels where the sun is, the shadow of the tree either looks longer or shorter. And when when it's at a certain level in the sky, when the sun is hitting it at a perfectly perpendicular to the long axis of the tree, then you get this accurate shadow that's almost the exact copy of the tree. But if the sun is high or low, you get either a super long shadow or you get a really shortened, smushed down shadow. And the exact same thing is happening with the central ray of the X-ray onto the sensor. Depending on the height, if you're too angled too high, then you're going to smush it down. If you're too low, you're going to elongate it. So let's look at the next one. And let me see if I can show you my other drawing. Oh, you know what? This isn't going to work because oh, shoot. I did it on both sides, and so now you can see the other drawing coming through. Hold on just a sec. Okay. Okay, so on this one, the pink, on this image, you can see that the BID is tilted down too low and all the central ray is coming up. And so the central ray is picking up the image of the apex and depositing it onto the sensor higher than the tooth actually is in the mouth. So the image ends up being much taller from here to here. It's actually much longer. I'm going to just color in this whole thing. So the image actually ends up being longer than it actually really is in the mouth. And that's because, again, the central ray is not perpendicular, it's angled. And this is more of an example of, I tried to make it more of an example of a parallel, because you can see the sensor is parallel to the long axis of the tooth, but the central ray didn't line up into the target perfectly. The person, you know, who was doing it still had it angled too low, and so then they got some elongation. So I don't know if that was helpful at all. I feel like that maybe made it confusing, but I felt like if you draw it out and you see where the central ray goes flying through the air and then where it picks up the image and deposits it onto the sensor, you can see that if it's not perpendicular, it's going to be distorted, or there's going to be an error. Okay, so vertical angulation errors are uncommon with bite wings. An example of a vertical angulation error on a bite wing. So here we can see that the cusps, we can see the buccal and lingual cusps. The maxillary cusps are superimposed over the mandibular cusps, and so when the patient bites down, something gets kicked out and it doesn't stay sort of parallel to the floor. You would notice that the whole bar and the target kind of tilt funny. And so a lot of times that gives you a clue that something isn't right. So sometimes you have to have them bite lighter. You have to have them even hold, like bite down lightly so they just barely touch the bite block, and then hold it straight so that you can see that you're centered, so that you're half on the maxilla, half on the mandible, and it's not like tweaked. Okay, tips to determine vertical angulation errors. So look for extreme cusp separation. If there's something that just their cusps are just not level, something is off, you know, everything looks maybe worn, or there's just a cusp that looks, you know, just their occlusal plane is just not even looking. That usually gives you a good tip right off the bat. Check the same tooth on the opposite side of the mouth and compare the size. Maxillary molar projection. The lingual root is always going to appear larger, and the buccal roots will appear smaller. So the palatal root on the maxilla, you have your 3 roots. The palatal root usually always looks bigger, and then that's the one that usually looks really elongated if you have elongation. Mandible anterior projection will often see the border of the mandible in the film. So a lot of times, especially when you're taking the mandibular anterior teeth, a lot of times you'll end up seeing the border of the mandible. And if it dips way down, like when you place your sensor and it dips way down like this, you know you're probably going to see. You want it to be more upright, but if it's like this when they bite, you know you're going to end up seeing the border of the mandible. Okay, some more technique errors. Cutting off the crowns. So here they've cut off the crowns. They've cut off the crowns here. Here we've cut off the apices. So what's going on? So sometimes what happens is the placement of the sensor on the bite block is off. You want to really make sure that when the patient bites down on the bite block, that you can tell that the whole tooth is going to be covered in the sensor. So if you've placed your sensor down too low, and some of their tooth might be below the sensor, if it's not centered, that could be one reason. Or if it's up too high, you might cut off the apices. So you want to make sure that your sensor is placed onto your bite block centered, nice and centered. And I know we talked about some things like with the bite wing tab, we said to off-center it, but with your PAs, you really want to make sure that it's centered so that all the tooth, the crown, and the apice. It's more important to get the apice. If you have a little bit of the crown missing, it's okay, because chances are you'll see it all in the bite wings. So, you know, that we usually are more concerned about being sure that we see the apice. Okay, a placement error can be any of the following: missing crown, mark as an error, but only retake it if half or more of the crown is missing. Missing apex always needs to be retaken unless you can see that apex in another film. So really look at all your films. If you are missing, say you took a premolar PA and you can't see the apice of the canine, but then look over at your anterior PA, you might have the apice of the canine there. So make sure you look really closely because you don't want to take retakes that you don't have to. Not far enough forward, not far enough backwards. And when we'll look at the critiquing the radiograph technique evaluation form next, but you want to shade the area of the box that indicates the direction the film should be placed to correct the error. So if you look at something and the error is placement and it's too far anterior, then you want to shade in what would be the distal part, so that indicates that you want to move back more. So shade the area of the box that indicates the direction the film should be placed to correct the error. All right, so here's our form. So when we look at a film, what we're going to do, oh, I cannot show you. Oh, I can show you. Hold on. I have little, okay, hold on. I have to go over here for just a second. Okay, so if when you are critiquing, you're going to take, say you're critiquing a molar PA, a maxillary molar PA, and say there is a placement error. You didn't get far enough back. You're too far forward. So what you do is you would draw an X. I'm going to make sure that you can see this. You would draw an X in the placement for P. And then I want to move my film back. I didn't take the picture far enough back, so I can't see like maybe there's a third molar, or maybe I just didn't see the third molar space. So what I'm going to do is I'm going to color in what would be the distal portion or the back portion of that little square. You see that? So you draw an X. And so if there is, let's say it's a bite wing. Let's say it's a bite wing, and you can't see the alveolar crest of the maxillary teeth. Then you draw a little X, and then I'm going to shade in the upper and the distal portion. So here, if that's a molar and you can't see the alveolar crest, I drew my X, and then I shaded in what would be like a distal, and then the upper. So that's kind of saying over here in the upper right, you can't see the alveolar crest, and so I shade in both of those areas so that I'm saying I need to make sure I get back a little bit farther and up a little bit farther to make sure that I'm seeing the area that I want to see on the bite wing. So we'll talk more about that, and I'm probably going to create an entire video where you see me critique several films. I'll probably do that and then post that here shortly so that you can see it. And then we can also talk about it in lab when we have a few minutes too, as I'm rotating through and you guys are critiquing your films. You'll pick it up really quickly. So each one of these boxes corresponds to a full mouth series. These 4 here in the middle, 1, 2, 3, 4, those are for the bite wings, and then all the other ones are for PAs. These are your anterior PA. These are your maxillary molar and premolar, maxillary molar and premolar, mandibular molar and premolar, mandibular molar and premolar. When you're in clinic, you'll have your faculty initialum. It'll just be me for your fall semester, but your spring semester, it'll be whatever faculty is critiquing them. And then you'll write down the technical errors, 1 point for each undefined technical error, FMX. Some of the stuff you don't have to worry yet. Number of retakes. This is more for, you'll fill this out more for when you've actually done a full set on a patient or when you're doing your proficiency tests. But then here over here on the side, it talks about the technical errors. So a placement error is you can't see the apex, you can't see the crowns, you can't see the whole tooth that you need to see. Horizontal, close contact, vertical angulation, elongation or foreshortening, beam centering, you cone cut, and then other, you just state, if something else has gone awry. And then whether or not you need a retake, you'll just put a big old R in the center here if it needs to be retake. If you've decided, yes, I absolutely need to retake something, then you put an R in the area of the film you want to retake. Oh my goodness, it does not want to advance. It just keeps clicking on my... There we go. Good grief. All right, so let's do a little bit of practice here. So let's practice what are the placement errors on this molar bite wing. So I wrote when it's obviously that it wants this to be a molar bite wing, but I thought to myself, if we didn't have that written up there, would we know whether this was a molar or a premolar? Because it's almost like right in the middle. Like you could say, well, they just didn't get far enough forward, or they clearly didn't get far enough back. But we'll go with a molar. And so if it's a molar, what are the placement errors? Well, they didn't fit. They didn't put the sensor far enough distal. So that's one of them. The whole entire sensor twisted in their mouth, so they didn't seat it firmly on the occlusion and made sure that when the patient bit, it didn't twist. So something twisted in the mouth, because now you're cutting off the whole apices and the distal of the second maxillary molar. You can't see the third molar space at all. We can see that there's horizontal angulation here and here. So we need to fix the horizontal angulation. Okay, let's go to the next one. Okay, another technique error is cone cutting or beam centering. So what's the error? So that the error with that is you didn't get the beam. You didn't get the beam. Oh, that's better. You didn't get the beam to cover your target perfectly. And so sometimes you have to have the angle, different for, like we were talking about this with a bisecting. You might have to have your angle different, but you still want to make sure that the whole end of the BID is covering the film. You know, if you're up too far or down too far or over or something like that, that's when you get a beam centering error. And how you fix it is you want to just make sure that you can tell that that BID is covering the whole space of whatever teeth that you're working on. So if you're using a target ring, it should be fairly easy. Although, I will admit, it is much more difficult in our clinic with the rectangle. It is easier to avoid cone cutting with a circular BID, so it is a little more tricky in our clinic, but it's as long as you see the little rectangle box in the target and you line it up, if you know, cross fingers, it works. Okay, and then you want to remember to always, and the way you fix it is you always move your BID in the direction of the white part. So in this film, for example, this molar film, the BID would have to move down. Criteria for FMX. So the ultimate goal of the FMX is to open all the contacts in the whole series. At least once, you want to see an open contact somewhere. All apices are visible at least once. You want to see 2 millimeters of surrounding bone around the tooth. And then you want to see all incisal edges visible. So like I said before, if you cut it off somewhere, you'll probably end up seeing it in a bite wing. So, you know, even if you cut off a crown somewhere, it usually ends up in another film. So if you're missing an apex, retake the PA. If you're missing a contact, go back and take a bite wing because that's easier to open up your contact. If you're missing both, retake the PA and try to open up the contact. So if in one area you closed a contact and you don't have the apex, go for the PA, but use your cotton and try and open up the contact in your PA. Okay, so supplemental x-rays. When the second molar is centered on your film and you still don't have the entire third molar, you do not need a retake, you need a supplemental film. So it's not an error. It's not an error and it's not a retake. It won't count against you, is the bottom line. It won't count against you if you did center your second molar on the sensor. But you still need to take another film so that you can see the apices and the distal part of the third molar if they're present. So, for example, placement error, second molar not centered. Here's your second molar. It's way back here. So that's a placement error and it's a retake. Up here, no placement error, second molar centered. So here's the second molar. It's centered in the center of the sensor. But you can't see the distal of the third molar and you can't see this apice of this root. So it's a supplemental film. So you do take another film, but it doesn't count against you. It's not an error and it's not a retake. So you don't, because you know, to pass, you'll need so many retakes, or you know, you'll only be able to have so many retakes when you're tested, and the same in clinic. So that's important to note. If your second molar is centered and you can't see all of the third molar, you don't have to do a retake. It's a supplemental film. That might, I don't know. Tell me if that's not clear. Okay. Error evaluation. If you can see crestal bone on both arches, placement is not an error, even if the arches aren't perfectly even. So if there's a little bit of a tilt, it may just be their bite. It may have twisted slightly, but if you can see everything, that's not an error that we count. So film number 1, placement due to not seeing crestal bone. There's beam centering here. There's horizontal here. There's placement we can't see. So there's several errors going on here. Number 2, placement is an error, but not due to the crestal. I feel like there's wording cut off here. So on this one, what's the error? Because you can see the alveolar crest on both arches, but what's the error on this image? Let's say this is a premolar. what would the error be? If you're thinking the error is that you can't see the cuspid, the distal of the canine, then that's right. If this is a premolar, which I am leaning toward believing that's what they were going for, then you can't see the distal of the canine, so that's the error there. Okay, what are the errors on the premolar bite wing number 1? So here we can see all of our alveolar crest. We can see the distal of the canine. These contacts are open. This is closed, but note that it's not even 50% into the enamel. So this would probably be okay, but it is horizontal angulation. It is closed. These are closed as well. So horizontal angulation is the error on film number 1. What are the errors on bite wing number 2? This is a molar shot. So here is our second molar, and it is not centered. However, you know what? I believe that this is a tipped, this is the second molar here, I believe. I think the first molar has been extracted, and this looks to me probably like it might be a wisdom tooth. Either that, or this could be a young person. But this still looks to me like an extraction and the tooth tip. So if this is the second molar, and this is the second molar, it still probably isn't centered. So I would still say this is a placement error, and it needs to be placed further back. And then there's horizontal angulation. That's a tricky one. It's a little hard to tell on this one. I'm thinking this is a wisdom tooth. Because see how that archway just kind of goes up here? That's the curve of sieve, I think, the curve of sieve is just that natural curvature of the occlusion. And then I think you can see the ridge there. But that's a little bit tricky. Okay, what are the errors on this premolar bite wing? So what are the errors here? Can we see the canine? We can see the mandibular canine. Can't see all of the maxillary canine. There's a little bit of horizontal angulation here. I would say mostly the film placement needs to go a little bit more forward, and then you probably wouldn't have to open this up, but since if you're gonna have to retake it anyways, if you don't get this tooth, if you're taking a full mouth and you get this area on another film and it's open, you don't have to worry about it. But if this is just a bite wing series, then you'd probably have to retake this and move it more forward, and then you'd try and open up this contact. What's the error on the molar on number 2? It's a placement error. You can't see the alveolar crest, and you can't see the distal of the second molar, and the second molar isn't centered, so it's not far enough back. So that's a placement error and horizontal angulation. Those contacts are closed. Okay, so let's practice some more. What could be some possible errors in this PA? This is a molar PA. I'm going to say that it needs to be set back further in the mouth so that you can get more of the second molar centered on the film, and that you can get more of the apex. You need to see 2 millimeters around the apex, and you really can't in this film. And then probably if you got back far enough, you probably would get more of this third molar. I'm going to say that this is probably a premolar film. Again, it's because your second molar is so far back that it makes you think they were going for the premolar. It's kind of halfway in between. And this is an error that I think you'll see a lot, is you really want to commit, like second molar centered, that sends you far enough back, far enough forward to get the distal of the canine. So it's pretty spread out. You're either really forward or your second molar is centered, which puts you pretty far back. You don't want to go for like just hovering somewhere in the middle, which is what's basically happening here. Again, if they're going to open up the premolar, because it's a premolar shot, your key contacts are in between your first and second premolars, and both of those are a little overlapped, so you want to open those up. These are open here, but it's closed there. Now, if it was a molar shot, that you can see there's a third molar, so this tooth needs to be way over here where the first molar is, and then these contacts need to open. But I think it was a premolar. This feels more like they were going for a premolar shot there. And again, in this one, they're not anterior enough. They haven't moved forward enough. You can't see the canines at all. The contact between the mandibular premolars needs to be open. And there's a little bit of a beam centering error right here. And then again, the canine should be centered, so it should be a little bit, maybe just a little bit placed differently, and they're cutting off the incisal edge, and then we have a beam centering error. So in this picture, you really want to, the goal is to open up the contacts between 7 and 8 and 9 and 10. It doesn't really look like with this individual it's possible. So sometimes you have to sometimes you'll open them up with a canine shot inadvertently. Sometimes you have to take more anterior PAs to open up these. Now, if you can look in their mouth visually and you can see straight through there, or you can see with transillumination, or the doctor can, then as long as they can see 2 millimeters around the apices of the root, which you really can't on this one, so this one would have to be also adjusted so that you can see more of the bone. That's the other error here. A lot of times, as long as the doctor can see the apices, they may not have you retake just to open contacts in the anterior, because it's easier to see in between teeth in the anterior. On this one, can we see the apices 2 millimeters around the apices? We can't, not on any of them. This one maybe, barely, but not in the molar, not in the premolar. So this one needs to be placed differently so that we can see more of the apice, because you need 2 millimeters. And also, the placement's wrong for, if it's a premolar shot, then you need to see some more of the canine. You need to see half the canine, and you want to see the apice of the canine. And if it's a molar shot, it needs to be back further. So they kind of, again, are hovering in this weird in-between place. Okay, we're talking about mounting a little bit. So traditional, when you're talking about mounting traditional film, the dot is always towards you. We'll feel some traditional films in lab, and there's a little indicator dot, and that would always be out towards you. So when you're mounting them in the actual physical mount, you would make sure that all the little bumps are towards you. If it's a digital film, you don't have to worry about if it's front or back. It just mounts it automatically for you. Here you can see the little dot here, and you can see the dot in here on traditional films. Mounting maxillary or mandibular film. So for maxillary, you're going to see in the molar region, you'll see the 3 roots. You see the you see the palatal root, and then the mesial and distal root on the buccal, mesial, and distal root. So on this image here, you can see there's a palatal root up in this area. It's kind of distorted and elongated, and then you can see the mesial and distal root. And then on the mandible, there's just, it's like 2, it's like legs. You just have mesial and distal root on the mandible. On the maxilla, you also have the sinus. You can see the floor of the sinus, this white line. This is indicating the floor of the maxillary sinus. That's another big clue that it's a maxillary film, not a mandibular film. And then anterior teeth are larger on the maxilla than on the mandible. So when you're mounting the anterior teeth, you know, the 8 and 9 are much bigger than 24 and 25. On the mandible, again, you have 2 roots instead of 3, and then you have the curve of Spee. I called it Spee before. The curve of Spee, which is a gentle kind of curvature, kind of almost like a smile of the curve of the occlusion. It just kind of like when you hold it all up, you kind of just see this little bit of a curve. And things look much flatter on the maxilla, and there's more of a curve on the mandible. And then you can see the exterior oblique ridge. You can just start to see it in this one back here. The farther distal you get, the more of the ridge you can actually see. And then again, anterior teeth on the bottom are much smaller, generally speaking, than maxillary anterior teeth. So if we were to look at these, let's say, are these maxillary or mandibular? So this film here, would you call that a maxillary or a mandibular anterior? It's supposed to be a canine shot. It's a little wonky. So what do you notice? Do you notice what's up here? To me, that looks like a sinus, floor of a sinus. And these teeth look fairly large. So I would say that this is a maxillary canine. And then if we come over here, does this look like mandibular molars or maxillary molars? These are two roots. And here, this is something you'll learn later on, but this space right here, this dark hole, that is actually the mental foramen where nerves exit. And so that's what that dark, so that's another clue. Besides the fact that there's 2 roots, that's another clue that that's a mandibular molar. What about this one? If we looked at this, we say, okay, this molar has 2 roots. And I almost feel like I see a curvature going down. Does that make sense for maxillary teeth? That there's 2 roots and a curvature going down? It doesn't. So this film is upside down. And so you would, if you were in your digital world, you'd rotate it. Or if it was an old traditional film, you'd just flip it upside down and put it the right way. So those are clues, those curves, the number of roots, the size of teeth. Here's another one. See how there's a little bit of a gentle curve? And then you can see a 3rd root in the center there, and then 2 distinct roots there. So this is the right way. This one's upside down. That's a bite wing that's upside down. And this is a bite wing that's the right way. All right. Mounting left to right. Here we go. We can see the floor of the sinus. All these little arrows are pointing out to the floor of the sinus, and that's a molar. And so if we had our film in front of us, we would put this one in the upper left. That would be an upper left. Because if you remember, if you're looking at something, x-rays are different, because if you're looking at your mounting, you think of it, though, being put on the patient's face. You turn it around and put it on the patient's face, or you turn it around and look straight at it. So it's difficult, and I can't even begin to explain that until I was wondering if I had a full set of films I could. But when you're looking at films, the right and the left, you have to, in your head, pick up that whole set of films and turn it around and lay it on the patient's face. That in your mind. So the left and the right get mixed up because when you look at it on a screen or on a table, it's different than when you place it on the patient's mouth. So here I'm looking at I'm looking at the left side of my screen. I'm looking at the upper left, but it's actually the patient's upper right. Oh, that's going to confuse somebody. So we'll talk about that in lab. That'll be a great discussion for lab. But when I'm looking at my screen here and I look at this film is in the upper left. But I know that I would take that off my screen, I'd turn it around, and I'd superimpose it onto a patient's face, and it would be their upper right. We'll talk about that more. Okay, so here's another film. I see two roots, and I see kind of a curvature. So this is an upside down mandibular molar film. And is it left or right? So what I have to do first of all is I have to turn it around. If I turn it around or flip it upside down, it'll end up showing in the lower right of my screen. So if I put that into a mount, I'd put that would show up in the lower right, but it's actually the patient's lower left. Okay, and now we look at this film. And this is one we saw earlier. We see this dark area here. We know that's the sinus. The floor of the sinus is this white line, and then the dark area is the sinus. So we know that that's a maxillary canine shot. And what we have to do is just like here, I'm going to go back. So here it is. So it's in my upper left, but it would actually be the patient's upper right canine. And then down here, we have anterior teeth that we can see are smaller than like 8 or 9. This is 24 and 25. And we know they're smaller. So we know that's a mandibular canine shot. And that's in the lower left. So then I know that's my patient's lower right. And that's probably kind of confusing. Like I said, we'll talk more about that in lab to clear up that mounting. And then you guys will practice mounting also. Okay, that was a long one. That was an hour. Take care, you guys. We'll see you soon.